need of routine antifungal susceptibility testing and correlation with clinical situation. My acknowledgement and conflict of interest. Okay, this is basically the most important slide. Well, this is just as important. Okay, so number one is at least where I come from, we only perform susceptibility testing for yeast. Okay, and we use basically the yeast 1 sensititer. Okay, number two is we don't do moles. And the most important thing, disclaimer, which I should have put in, that I'm not a microbiologist. So the microbiologists on the floor, please spare me. All right. And so, of course, I was a little taken aback when the question was posed. Who posed the question? Okay. Yeah, I can see the smile. All right, so I decided to take this question and take out keywords like what we do for our MBBS exam. Okay, when you have a question, then you try to answer it. So I put up these words: routine, correlation, and clinical situation. So I'm going to start off with the first word, routine. So what is actually considered routine in your institution? Okay, routine for some may not be routine for others. So if you speak to Paul Verwey, Michael Adenrock, and Juan Louis, they will tell you that routine is this. Their routine is basically EUCAST or CLISI, which means that you are faced with the transatlantic war. And even between them, where I know they are trying to come to a reconciliation and a marriage, but you can see that actually the methodologies for them, which AKA is the reference, international references. Okay, and of course, likewise, through the result, as a result, there's also differences in interpretation of breakpoints. Whereas for us simpler folks, routine means simple tests like the e-test, this diffusion, or even easier, put it through the VITEC. Or so some of us who want to do a bit more, get our hands dirty, we basically do the sensititer, as you can see in here. So, which is which? Then, of course, how exactly are breakpoints determined? So the clinical breakpoints are actually, of course, different from the MIC breakpoints that the two sides, ID and microbiology, try to have a consensus with. So I had to force myself to introduce this term called the ECOF, which is basically the epidemiologic cutoff point, which is basically what people do when they have got a bank, very simply a bank of fungi, Candida, Aspergillus, and they go and do susceptibility MIC testing for all the specimens, irregardless, blinded. So they of course get this normal distribution curve. And the ECOF is actually cut off at the upper limit of the MIC. Okay, but having said that, that actually may not constitute the clinical breakpoints, which actually takes into account other factors, like the dosing regimens that's available in the market for the antifungals, the PKPDs, as well as more importantly, which I will talk about later, the MIC clinical outcome correlation. So the clinical breakpoint may actually be somewhere further away. And likewise, over time, this is actually a moving target because as with changes in epidemiology, changes in epidemiologic resistance patterns, the ECOF may actually shift, all right? But the clinical breakpoint may or may not shift. So that is why, of course, the need for us to always survey the resistance in among our bugs, our patients, every once in a while. So this is as such how breakpoints are actually being achieved or being established for international guidelines. So of course, all of us look up to EUCAST or CLISI. And you will know too, because of the differences in methodologies, which till now they are trying very hard to reconcile. I'll just take a few examples. So there are actually breakpoints for some, not for the others. Of course, the one that's pretty much the most established and being still being talked about are that for fluconazole, where of course when the breakpoints first came about, people were shocked. The Americans were shocked by what the Europeans had done, whereby they used the cutoff of more or less than 2 as that for Candida. Whereas, as you can see too, that CLISI still like to retain the sensitive but dose-dependent category. And likewise too, the controversies or the difficulties recently with establishing breakpoints by EUCAST for caspofungin, while that, in contrast, for antifungal is well established. So you can see that actually there's actually intrinsic difference between most of the time, the differences between EUCAST and CLISI are ±2 dilution, so not that bad. Okay, but of course, the one that is quite glaring is for glubrata, where CLISI has sort of decided that they are still going to keep to SDD with a cutoff of 2 versus that of EUCAST. All right, so these are some of the differences that I'd like just to highlight to you. And then the next question is that how about between references between the standard reference cutoffs as well as that of the accuracy when you use a commercial assay, which most of us for practical reasons actually do it. So we can see that actually there is actually quite a lot of concordance, giving us the confidence that the commercial assays are reliable. Usually the concordance is between 95 to 97% as compared to a reference standard, be it EUCAST or CLISI. You can see here in all its different permutations. It compares well, and of course, from our very practical point of view, they are easier to perform in our service laboratory. Okay, next, the word correlation. So, of course, for us clinicians, the biggest thing is, what is the implication of the MIC in terms of outcomes for a patient. So this is what you generally expect to see, or at least the justifications why there are clinical breakpoints and set as they are, is that actually it is meant to at least establish in the presence whereby you want to show that when there is an increasing MIC, there is actually a decrease in clinical response. And this is what actually Michael and EUCAST actually did to put a cutoff at 2, based on what they see in collated from the studies to date of patients with Candidemia for MIC of 2 for fluconazole against Candida. And then, in all their justification, they try to say why EUCAST may actually be better than CLISI. And of course, the glaring part is actually here when what they did was that they actually looked at patients with Candidemia for one cohort and broke them up using either EUCAST or the CLISI criteria, as you can see here, and then to show the people that you should be expecting the trend whereby MIC goes up, response goes down. And they were trying to tell the rest of the world that ours is better, EUCAST is better, because this is alternative is EUCAST, whereby if you use the CLISI criteria, there is this glaring SDD here, which actually was nowhere here, nowhere there. Whereas if you had been very more clean cut to use a cutoff of less than equals to 2 or more than 4, the picture is actually much better in discriminating between patients who would do well with a sensitive fluconazole sensitive strain versus one whereby the MIC is more than 4 and patients do worse. So of course, following that, others have also followed in the subsequent years to demonstrate how fluconazole MIC and more precisely those above MIC, those over MIC ratio correlate with actually a therapeutic response. So in this study, they used actually a therapeutic dose over MIC of 50. But I think in my practice, usually I use at least 80 or 100. I target a 50 or 100 to at least give me at least the self-imposed confidence that the drug is working. But here, the minimum is you would expect when you dose your patient is a ratio of that or more than 50. But having said that, for all things that you say black, there's always people who will say white and vice versa. So there were people who actually say that, while this rule for breakpoints should stand in most situations, there are of course cohorts whereby there is no clear correlation seen, be it in the case of ANFO-B, or of course the other people would say that looking at other antifungals like caspofungin, that the MIC actually can correlate with outcomes. So just be aware that there's always differing data, pros and cons, but I think the general concept or the general practice holds true that the intention of the breakpoint has to only make sense in the context of the patient outcome and nothing else. Okay, next, I'm going to tackle the word clinical situation. So I'm going to run through with you some scenarios that I think all of us encounter very often, and how these situations actually highlight this question that is actually brought about need for routine testing versus correlation with outcomes. You realize that actually the majority of this talk is in the context of Candida because this is where the most has been done and studied of trying to correlate MICs with outcomes for antifungal testing. But of course, I'll move on to the lesser, more grayer areas later on. Scenario 1, okay, straightforward. 40 years old, basically had a road traffic accident and the bowel spilled out, had an op done, basically was covered with IV augmentin after the operation. Fourth post-op day, fever, blood cultures drew Candida albicans. Very common, right? So this one, okay, you can follow what is published not too long ago, but which still stands true. Okay, what has been described or what has been generalized, that for what we think are intrinsic susceptibility for some Candida species. You can see here what they have, how the international or the folks from the West have said that for Candida albicans, generally they are sensitive. Likewise, glabrata, believe it or not, and likewise, then you move on to so it's tropicalis and glabrata, whereby there are some gray areas, and then the more troublesome Candida, as you can see here. So to summarize all these, I'll just say this, make some general statements. Is when I see Candida albicans, I don't think twice about trying to find out what's the sensitivity. I take them all as sensitive. Okay, I mean, even if the test is lost, it's all right for sensitivity testing. Okay, so but as with all things in life too, we don't use the word definitely, almost all, because, well, Prof. Chen is here. She had one paper that said that Candida albicans in her country, only 97 or 98% are sensitive, right, Prof? Yeah, so, okay, so with some exceptions, but this rule almost always holds true. Scenario 2, 66 years old, from oncology unit, had basically, gastrectomy done for cancer on TPN, then got fever, and the blood culture is C. tropicalis. She was put on fluconazole, which is what all of us do, because the MIC was 1, sensitive, right? But then the fever rages on, and then she has got endophthalmitis. So will you change treatment or will you stay course? Scenario 3, 68 years old, okay, ALL on chemo, neutropenic, had a thigh abscess, and likewise in the blood, growing Candida tropicalis everywhere, whereby the MIC is 128, and the Vori MIC is basically just as bad, resistant. So remember the slide that I showed you from Micon, okay, that says that Candida is sensitive all through, and Candida tropicalis is sensitive all through, and I think this has really been brought about a few times. This is probably the 3rd or 4th time this is being shown in some way or other, whereby we know about the story about tropicalis in our region, as well as the susceptibility. As you can see here, basically, I don't think you can read it, but basically there is actually concern about reduced susceptibility of tropicalis in this part of the world, in Asia Pacific, and not just in Singapore, but in Taiwan, I'm sure in India as well. Okay, so what's the cause of it? And when we actually look at some of the more resistant strains that we actually have been seeing in the recent 5 years, we found that actually there's almost all of them, the mechanism involved is actually ERK11, which is ERK actually mediates the production, the gene mediates the production of lanosterone demethylase, which is the target where the azoles worked. And we found that quite a lot of the patients with C. tropicalis, which were resistant, was actually harboring, at least C. tropicalis was actually harboring this mutation. Okay, so, well, the sequence is actually here, as you can see. All right. So again, we know too that C. tropicalis in the context of cancer patients are more fulminant for some reason or other, seen both in animal studies as well as in patient cohort. And then the question to be asked is, so what is the best treatment for C. tropicalis if in face of these issues? This is actually I won't call it a meta-analysis, but it's actually a review of all the studies to date, the fungal studies for which we then went back to the individual authors and tried to decant the patients specifically with Candida tropicalis, because that is our interest in this part of the world. All right, and what was notable in that, well, in the Lancet paper by Bakyan, the C. tropicalis patients who actually received not the azole therapy as well as echidocandins actually didn't do well for some reason. And I broached this issue. Well, David didn't thinking that I was mad to include this in. And with deoxycholate, whereby we said we should persist with Ampho-B as being one possible option in Asia. So, at the end of the day, we ask ourselves, we know that, we know that C. tropicalis is a problem here. And there's actually increase in pattern of resistance, especially in those patients who have seen azole previously. And more recently, I've seen one whereby, the patient is resistant to everything other than amphotericin B. When I say everything, it's basically all your azoles, from fluconazole, Vori, Posa, as well as all your echinocandins with the FKS1 mutation. Not 2. We only saw FKS1. So, so in retrospect, there might have been some wisdom when we left that clause in that review paper that we recommended deoxycholate or amphotericin B preparation as an option for C. tropicalis infection. Scenario 4, 45 years old, ovaries, malignancy with the stuck down peritoneum as such has got right hydronephrosis, had got PCN, DJ stent. And then after that, the procedure, the patient had fever, diagnosed as having UTI, urine culture send, blood culture send, growing C. glabrata. And then the microbiology lab reported saying the glabrata was resistant to fluconazole, sensitive to anisula fungin. What will you do? Will you start anisula fungin? And then, well, we decided to call up the lab. And then the laboratory said that actually the fluconazole MIC is 4. And then a NIT is sensitive, right? 0.032. So how do you interpret that? So of course, the laboratory is, microbiology is obliged. Remember the thing I'll talk about, ECOF versus clinical breakpoint? Okay, so when your clinical breakpoint actually can be lower than your MIC, but the lab by EUCAST criteria is still obliged to report it as resistant. I think you guys know that. All right, so it was actually 4. So it may be like borderline, or you call it resistant by EUCAST, but SDD by CLISI standards. So what we did basically was that we actually proceeded to treating the patient with fluconazole rather than echinocandins for obvious reasons. Number 1 is the penetration of echinocandins into the urinary system, and number 2 that you remember too that the thing about AUC or dose over MIC, where we feel pretty confident if we are able to supradose the patient with a AUC with a dose over MIC of more than even 100, we should be achieving pretty decent drug therapeutics, which is what we did. So for scenario 4, in summary, is for glabrata, it may be better to not just receive the word yes, no, susceptible or resistant, but to pursue it further to ask what exactly are the results, the MIC in terms of numbers. Of course, the disparity between EUCAST and CLISI, the transatlantic war. And then, I don't know about you guys in Malaysia, but basically all our glabratas in our institution, I would say not all again, almost all, the MIC is very special. It's always between 2 to 8. Is that what you guys see in Malaysia? You don't get those nasty MICs in Duke or in MD Anderson where all the glabratas MIC are in 3 digits. But in where I am, I'm pretty sure in Singapore as well, Prof. Chen is nodding in Taiwan, it's quite a friendly glabrata, The MIC is only 2 to 8, so which means that actually, despite all the guidelines that you read about elsewhere in the West, you can actually use a higher dose of fluconazole to treat. Of course, the penetration issues of echinocandins, just to highlight the teaching point from scenario 4. Scenario 5, germ cell tumor with border care, fever, hypotensive. Okay, blood culture. So got line, and there's a blood culture growing C. parap. And the parap was actually, the lab reports as sensitive, really sensitive, gives you the numbers this time around, and it's sensitive to both fluconazole and echinocandin. Here we have been using a NIT testing, so a NIT is reported. So what will you do? Glabrata is a very special, I would say, a slightly different ball game. I think many of us who are in this field will say that you view it a bit different from the rest of the Candida species, and I think this can be better illustrated in words by some of the comments that people have made. That from some of these mega trials that you see here, as well, all of us are well familiar with. There was some observation. There was some numerically higher numbers of persistent candidemia from Parab, okay, in the echinocandin arm. Okay, that means more in the so-called treatment arm. And the eradication clearance is actually lower with echinocandins compared to azoles. All right, and then of course the David Andy's patient level meta review. There was a univariate analysis that, of course, by the time you go to multivariate, it was lost. But they actually made the observation that echinocandin appeared least effective for Parab. And headwise too, in our local data, we found that as compared to the rest of the Candida species, Parab actually had the right shift when it comes to caspofungin. But this actually may or may not be seen in your institution, but we just happen to see it. Okay, as compared to the rest of the azoles, where you see it's here, Parab is here. And so there is actually some concern now that irregardless of what you see for your echinocandins MIC, that beware when you're giving echinocandin to a patient with C. Parab, because of these clinical observations which may or may not be independent of the actual echinocandin MIC. All right, so these are clinical observations which may not correlate with your actual laboratory susceptibility testing. And as such, fluconazole is a good choice for C. parabsilosis. So I'm going to leave Candida now, but just in summary to say, to summarize all the slides before, to say that, of course, we must be mindful about the intrinsic resistance traits for the individual Candida species, some novel mechanisms of resistance that we have noted in the region, and of course, special cases with certain Candida species as exemplified by glabrata and parabsilosis. Okay, this one, quite easy. Cryptococcus, because there's nothing much to say about. Okay, so 60 years old, post-renal transplant on the usual triple immunosuppressants, headache, classical headache, neck stiffness, LP done, white cells seen, C neoformans with an MIC of 2, which is sensitive. Right? The cutoff for CRIP, if I'm not wrong, is 8. So this is just to illustrate the fact that a lot of Cryptococcus to this day and age, and the way in which we manage our cryptococcal patients are actually based on the HIV cohort. And a lot of what we do now, beyond the triple therapy HIV treatment era, is that we are seeing more crypto in our immunosuppressed patients. And unfortunately, though, because of the smaller patient numbers that's seen in clinical trials, a lot of our advice and recommendations are still extrapolated by the HIV cohort in one way or other. So again, this is the studies from Prof. Chen from Taiwan, where what has been reported, which is, I think, representative of this region, is that the cryptococcal species that are seen in these regions are actually pretty much sensitive to both fluconazole and ambizones, with very few exceptions. And to bring Malaysia into the limelight, cases of GTI have been reported. In contrast to Singapore, whereby we hardly see any. And then the requirement for extended treatment has been recommended, though duration-wise, in terms of duration, though the outcomes I don't think are any different. Proposed breakpoints, again, controversies in whether or not high MICs may or may not be related to differences in outcomes. Okay, I'm going to rush because I noticed there's only 5 minutes left. Okay, so the summary for scenario 6 is that basically anything beyond Candida we know very little about, and there is less consensus, and of course, more to come. Basically, in short, most Aspergillus. So this is a patient post-liver transplant who basically was intubated for pneumonia, has got A. fumigatus tropicalis. Till now, I can't remember why we ever sent this, because I told you we never do susceptibility testing. This was actually sent to Mayo Clinic. Oh, I don't know why. Okay, so basically, this one, the VORI MIC, if I'm not wrong, the cutoff is 2. So people are a bit worried whether VORI MIC is 1. Then CASPO, sensitive. So will you start CASPO or VORI with a close to cutoff MIC? So you have heard from the earlier speakers about the issues of azole resistance. Tandem repeats 51, L98H that's being reported and spreading out, first coming from Netherlands. But having said that, very easy. Aspergillus, we don't do it. Of course, that's the excuse we say, because we quote the IDSA Aspergillosis Guidelines 2016, which states that routine antifungal susceptibility testing is not needed, despite all they have heard from Europe. And this is the test that my previous unit in Nijmegen does. This is where Paul Verwey actually does his very nice 4-well experiments. The 4 wells containing Itra, Vori, and POSA. This is the control well, where at fixed doses, where you receive growth. These probably have got triazole resistance. And then, of course, Paul, who is a strong believer and a proponent of azole resistance, will tell you that basically patients do badly. Okay, but you have to be aware too that the patients who have got triazole-resistant aspergillosis also tend to be patients who actually have been ill for a long time, and of course there are other comorbidities that may attribute to this. And of course, through the spanner to the works, then Dimitrios, M.T. Anderson actually came out with this recent paper saying, hey, there's no diff between MIC and outcome for aspergillosis. So for that patient, we basically just went ahead and treated with voriconazole. That was 2 years ago. Now he's actually still well and alive. So correlation not well ascertained, and there's no recommendation for routine testing, only if you think something is wrong, suspect resistance, or basically you just want to write a paper. Okay, scenario 8, last one. Okay, so 54 years old, post-transplant, GVHD, basically on multiple immunosuppressants, coming in with flu-like illness, PIV3, which is basically the thing that we hate most when we see PIV3, do badly. Basically then, while in the ward, was intubated for respiratory distress, chest X-ray shows multiple lung nodules, ETT, fusarium. This is the bug again that all of us hate because difficult to treat, especially if you see Solani. Solani is one of the worst, basically. I would say game over when you see it, it's bad. All right, so you hope when you see fusarium, it is a non-Solani, be it it's called Vertilicides or Oxyposporium, hopefully. But you can see here that the MICs are actually very high for Solani. Okay, but having said that, so you have your MIC, it seems as though it's game over for the patient, right? Okay, but Olivia actually went on, of course, we do too. We go on to some form of treatment, and here they have tried with voriconazole with success. You can see not relative success, not that bad, where at least they were able to salvage half of the patients and ensuring that they survive for the next couple of months. All right, so likewise, ESME has come up with some guidelines for treatment of these rarer fungi. But the thing to highlight here is you can see all of them, the quality of evidence is actually grade 3, which means expert opinion. Okay, nothing scientific, just what we feel, what we do. Right. So scenario 8, rarer moles. Okay, little is known, don't know what to do about whether or not susceptibility, MIC versus outcome. Laboratory evidence. So at the end of the day, my parting second last slide is that, as what has been emphasized by all the previous speakers, everything is dependent on the host, because everything is actually a triage between how the host is, how you treat, and how the fungi responds. And it's actually a very complex dynamics and interaction between all these various factors that determines outcome. And with that, I think I end the talk. Yeah, thank you very much.